Good morning, good afternoon, and good evening. Thank you so much for joining us today for Nothing Without Us, Civil Society Solutions to the COVID-19 Pandemic. My name is Jim Pickett, and I work for AIDS Foundation in Chicago, and I'm a member of the CAB, the COVID Advocates Advisory Board, COVID Advocates Advisory Board. And we're really delighted to be here today, partnering with IAS-USA on this webinar.
The IAS-USA designates this activity for a maximum of 1.25 CME credits. Generous support for this activity has been received from the following contributors.
I want to give you a little bit of background on the CAB, and we'll be introducing our global panel. We have amazing friends from all over the world joining us today, from Thailand, India, Uganda, the United Kingdom, and the United States. So before we get into that though, I just want to give you again a little bit of background on the COVID Advocates Advisory Board. And I'm going to drop in our website in a second so you can check it out. This was a group that was formed about a year and a half ago, really with the leadership from AVAC, ITPC, the International Treatment Preparedness Coalition, and TAG, Treatment Action Group. All groups that really focus on HIV, that pivoted and expanded their work to include COVID in the last year and a half. So who is the CAB? What is the CAB? We're a group of civil society organizations and global health advocates committed to the principles of good participatory practice. That relevant stakeholders will be consulted in the design and conduct of the research in which they are invested, and that both ethical standards and scientific endpoints will be served better by doing so. This commitment comes from our engagement with human rights, social justice, and health equity. Currently, we're about 125 people from all over the world: Argentina, Armenia, Australia, Bangladesh, Botswana, Brazil, Canada, Cote d'Ivoire, France, Greece, India, Ireland, Kenya, Malawi, Morocco, Netherlands, Nigeria, South Africa, Spain, Switzerland, Thailand, Uganda, United Kingdom, United States, and Zambia. And maybe that includes you. And if you aren't involved with us, you are interested in becoming a member, you will see a link that you can do that on the website when I drop that link into the chat. We recognize that the unprecedented nature of the current public health crisis demands innovative thinking regarding the nature of community engagement. And given the breadth of content, diversity of issues, and potential advocacy actions, CAB, the COVID Advocates Advisory Board, work is divided into 3 parallel work streams around training and information, access and advocacy and communication issues, and research progress. We can talk a lot more about the CAB, but I think it'll be much more interesting to dive into the discussion momentarily. But before we really get rolling, we do have a couple of really quick poll questions for you to answer. We want to get a sense of who you are and where you're coming from around the world today. So Jose, if you wouldn't mind putting those poll questions up for our audience to answer, that would be fantastic. So 2 quick questions. What is the primary setting of your work, and from which continent are you currently viewing this webinar? And we have our results already. Wow, that was very fast, thank you. So we have a really nice mix of folks from advocacy, NGOs, with some medical practitioners, and in terms of people coming from around the world, a nice split, heavy on North America, but a nice array of folks and friends from Africa, Asia, and Europe. Welcome everyone who is here with us today. Now, one of the reasons why we decided to do this call as members of the CAB and bring this to IAS-USA is that we know that HIV and the work that we have all been doing in HIV for the last 40 some years around research and science and program delivery from on the ground all the way up has been instrumental in the COVID response globally. We wouldn't have vaccines, we wouldn't have the kind of public health response had it not been for all the work that folks working in HIV have already done and stepped into the breach when COVID hit and pivoted and turned their labs into COVID labs and started doing contact tracing, not just for syphilis or for HIV, but for COVID. The response has really been driven so much by folks working in HIV. And that really also includes people on the ground, people doing advocacy work, people in civil society. It hasn't been just scientists and medical practitioners, it's been us on the ground who have also jumped in and figured out how to bring our expertise to this effort. And I think what we're going to talk about today is both what we've brought to the effort from our HIV experience, but also what we've learned from COVID that we can take back to our HIV experience on the ground. And I also just want to recognize before I go around and have folks introduce themselves, is that while the COVID pandemic is improving or waning in certain parts of the world, in other parts of the world, it is still quite catastrophic. By no means is this over. Only a small percentage of inhabitants on this planet have received vaccines. So there's been extraordinary vaccine nationalism or apartheid. It's been very uneven. Public health responses have been uneven. Politics has played problematic roles in many cases, sometimes good, but often problematic. So I don't want to, while there is some hope and we have turned the corner in some parts of the world and in some ways, I don't want us to give ever the impression that we're somehow closing off this chapter and we're ready to put COVID behind us, because COVID is still quite squarely in front of us. So with that said, I'm going to ask our panelists to introduce themselves and give a short little bit of background about what they've been doing in terms of HIV, and then we'll move into later how the pivot has happened in terms of COVID. And I'm going to start with folks who are the latest in the day, who some of us are drinking coffee and some of us are maybe having margaritas or cocktails right now. I'm going to start, I'm not sure what Midnight is having, but I would love Midnight to introduce himself and tell us a little bit about his HIV work.
Oh, hi, Jim. Hi, everyone. Good evening from Bangkok. I'm having water, and I've got proof here. It's not vodka. So I've been working in APCOM, which is a regional community-based organization, working in 30 countries in Asia-Pacific region, starting in 2007, working on HIV advocacy, and now moving towards LGBTI human rights in the region. So I've been with APCOM for 10 years now. A lot of our work on HIV has been around the, what we're famous for is the advocacy on pre-exposure prophylaxis advocacy in the region since 2014. And we're doing work also on ensuring there is more community-led interventions, particularly using social media to reach the younger gay men who are basically the populations that we need to reach in the Asia-Pacific region. So thank you for for inviting me and APCOM to share experiences on COVID-19.
Thank you so much, Midnight. And I definitely do want to call you out for incredible work you've done on PrEP. I think your social marketing and messaging are amazing for so many reasons, but the PrEP stuff was certainly very inspirational. So thank you for that beautiful work. Let's move to our friend Shobha in India.
Hello, everyone. Namaste. A very good evening from India. I'm Shobha. I'm founding managing editor of CNS, which is a policy, communication, and advocacy initiative for health, gender, and development justice. And my focus is on advocating for rights-based solutions to our problems, including the HIV community and others as well. Thank you. And I'm really grateful to IAS-USA for giving this space for civil society solutions to COVID-19 response, because this was one missing cog in the wheel in the lockdown that was clamped in my country, and I think in some other parts of the world too. Thank you.
Thank you so much, Shobha, who excellent journalist. I've been interviewed by Shobha a number of times. I think the last time you interviewed me in person was a few years ago in Madrid.
Yes.
And I was starting to get a cold, and by the end of the conversation, I could hardly speak. So you left me speechless, Shobha. Thank you for being here and for joining us in the evening in India. Let's turn over the introductions now to Winnie in Uganda.
Good morning, good afternoon. My name is Ikilai Winifred, and I work with the National Forum of People Living with HIV, and I'm a current fellow with AVAC, and my advocacy is centered around ensuring that the test and treat policy is implemented effectively. And currently my work is hinged on ensuring uninterrupted access to treatment among basically that's what I'm experienced in HIV prevention research and advocacy, but also I've been coordinating the DREAMS program in Uganda.
Thank you so much for being here with us, Winnie. And I think there's a slight internet issue with your feed, so it might be good to just go off camera. We'll still see your beautiful picture, and hopefully we'll be able to hear your beautiful voice. Just slight internet problems there, but thank you so much for joining us today. And now I'm going to pivot over to Simon, dialing in, zooming in from the UK.
Hi, Jim. Thanks for that. I'm a HIV positive treatment activist. I track advances in treatment, and that's increasingly included PrEP. And for the last year, though, I've been mainly following COVID-19 research in order to explain and understand the implications for HIV positive folks. And also I'm involved in various community networks in terms of being a bridge between community and researchers. And so I'm interested in representation, community representation in research.
Thank you, Simon. And I certainly have appreciated your ability to wade through what is really an avalanche of research that has been hitting us day in, day out for the last year and a half. So we're going to be asking you for some tips on how you have done that and made sense of all that. It's really overwhelming to try to keep up with every piece of new science that is coming out and to sift through things that are legit and some things that are not as legit. And finally, last but not least, from the United States, Rob, why don't you go ahead and introduce yourself?
Greetings. I'm Reverend Rob Newells Newton, and I serve as the Director of National Programs for Black AIDS Institute in the United States, where I get to help lead all of our training, capacity building, workforce and community education programs, as well as our policy and organizing wing, which includes our National Black Treatment Advocates Network with 26 chapters and affiliates across the country. And I get to help lead our direct services team in Los Angeles, where we do HIV testing and linkage and support services. But I am stationed in the Southern United States in Georgia.
Georgia, from California to Georgia, Rob. Rob was recently an Oakland human for a long time, recently just moved to Georgia, where some of the politics are a lot more challenging than maybe parts of California. And yeah, we look forward to talking to Rob more about addressing COVID amongst populations in the United States. And as we know, like HIV in the United States, COVID has hit hardest communities of color, particularly Black and Brown communities. And so organizations like the Black AIDS Institute have really played an important role in the civil society response to COVID. So we'll be hearing more about that shortly. So, and I will also say, folks who are on this call participating, we got a lot of questions in from you. Thank you for that in advance. You can also leave questions in the QA, on the QA box on the bottom part of your screen. The chat is open for you to make comments and to chat with each other. But if you have a question that you want asked, please put that in the QA. We'll do our best to get to all of these in addition to the questions that were sent in advance. And my apologies in advance if we're not able to get to all of them. There's a lot, so I basically am saying I'm sorry already. We probably won't get to every single question, but we will certainly do our best. Let's start back. Let's go back to Thailand and ask a Midnight a question. So community organizations have played a really crucial role in reaching the most vulnerable folks during COVID. And they also find themselves providing humanitarian support. What has been your organization's, APCOM's, experience on this? And where do you see the gaps?
Oh, thanks, Jim. Well, Thailand is one of the first countries that went into lockdown and has got the COVID cases outside China. So it's really well, hard to believe now. So it's been over a year already. We pivoted really quickly in terms of ensuring that we have evidence from the communities on what's happening on the ground. So as Thailand went into lockdown towards the end of March last year, we started collecting data to do this COVID-19 series since April last year. So we're now on our 25th issues of the COVID newsletter series. So we've collected over 100 community stories from across the 30 countries in the region. In the beginning, within Thailand, in terms of the needs, it's really about the emergency funding to purchase PPE, sanitizers, and face masks. And that was, helping to write proposals to the community groups because there is an emergency funding mechanism in our region. So all of the emergency funding is from outside the region. So we have to look at applying for that. And APCOM became the kind of like the fiscal support for organizations that are not registered. And so we can receive that funding. Communities on the ground that are able to kind of like do the community drop-in centers or already doing HIV testing, they were looking at ways on how to provide that by pivoting to online appointments and making sure that they reduce the numbers of people coming in at a time. So you can make appointments during slotted times and ensuring that there's less people within the clinics itself to ensure that the risk of COVID-19 is reduced. The gap certainly, now we all know that it's more than just the PPEs purchasing. It's about the livelihoods of the communities on the ground, and emergency funding alone is not enough. So it's really about how do we ensure that structurally vulnerable communities are able to access other humanitarian needs, and they are going to the community-based organizations for that. The governments, really should support the community-based organizations to reach the most vulnerable. So that's what we've been seeing, and that is the current gap that we're seeing, and it will be like this for foreseeable future, since the rolling out of the vaccine has been sporadic in our region.
So are you seeing, and just a quick follow-up for you, Midnight, are you seeing, in terms of vaccine rollout, where vaccines are available, are people pretty willing to take the vaccines, or are you seeing folks who have levels of mistrust or distrust or hesitancy around being vaccinated?
So many discussions, Jim, and a lot of it comes down to communications and messaging. And if there is no trust, I think whatever the options you have, people will not trust that. And now with social media, a lot of news spread really quickly. So within Thailand, even though comparative to other countries, we don't have that massive cases, but of the fear, and because we're now currently in a third wave, people are very afraid. More afraid than last year, I have to say. And the rolling out of the vaccines by the government has been very slow, and it's not clear. So because there isn't a clear messaging, there's so many misinformation. So we actually have to do a special newsletter just on COVID-19 vaccines, and we have to get the community leaders who are working on HIV to come out and talk about experiences of getting the vaccines, so that it will ensure others will not be afraid to take the vaccines, and why it's important for us as community leaders to give out those right messages, because we need each other to be able to support us in this really changing environment. And if we don't have all of us together to move together, we're really not doing the work that we're supposed to do for the community. So if our community leader is not able to work, is not able to be physically, mentally, spiritually strong through this, then we are losing the momentum as well.
Thank you for that, and highlighting just the power of personal stories and having leaders and stakeholders and influencers telling their personal stories and to help break through some of the misinformation that's out there. Shobha, I'm going to pivot to you in India, where the news that we are seeing on our screens is just, it's scary and devastating. And I just love to hear from you, what has, if you can characterize the impact on communities there, starting with the first major lockdown imposed by the Indian government last year and kind of where you're at today. Tell us what's going on in India.
Yes, as you said, it is scary, it was scary, and it is still scary. And because there was an initial complacency followed by draconian measures with lockdowns, intimidations, use of police force, gagging of press. We know that WHO declared COVID-19 a global pandemic on March 11, 2020. But our Prime Minister said on March 13 that there was no health emergency in the country. Then on March 24th at 8 p.m., he made an announcement. He addressed the nation, announcing one of the world's strictest and longest countrywide lockdowns at just 4 hours notice, because from midnight at 12, everything came to a halt. It was a politically ill-conceived, ill-implemented lockdown, even if there was a public health rationale behind it. Stepping out of the house, unless for an essential purpose, became a punishable offense. Buses, trains, planes, all economic activity stopped, and we had no time. The public communities were not given any time to prepare for it. And as you must have seen in the newspapers or reports, that it triggered a massive, heart-wrenching exodus of migrants and daily wage earners due to the sudden shutdown of workplaces. They had nowhere to go, no earnings, no food to eat. And millions walked or cycled hundreds of kilometers to go back to their native villages. Many walked on railway tracks to take the shortest route to their places. And as per government data, after 15, 20 days, they started moving the goods trains because supply chain was disrupted totally. And more than 8,700 migrants were mowed down by railway trains as they were walking on the tracks, or maybe they slept on the tracks just to escape the police. They wanted the shortest route, and the police was harassing them all the way. And the lockdown should have been there to break down the chain of transmission. But what it did was it added unnecessarily to the miseries of the people. Diagnostics, treatment, care, and support for existing non-COVID health issues, they went for a toss. All outpatient departments and hospitals were closed. In fact, my own relatives and friends, they were running to get their chemotherapy cycle completed, but the hospital was not allowing them entry. And there have been harrowing reports of increasing cases of sexual and other forms of gender-based violence also within homes. Even COVID-19 patients have been raped inside ambulances. And just a few days ago, from my city, Lucknow, there was a news report that a woman was raped inside the ICU. She was there for COVID treatment. She died, unfortunately. Yes, there were some states who really responded in a better manner, but the approach of all states run by the right-wing ruling National Party was neither based on human rights, nor was socially just, nor was it people-centric. And this only fueled the mistrust of the common public, which we already had of the government. Government actions in these states at times was criminalizing transmission. They profiled the infected people and blamed them for infecting others. They intimidated and took police action against doctors and private hospitals who had put up public notices that there was no oxygen supply in the hospital. You must have read about that. There was a huge shortage of, in this second wave, there was a huge shortage of oxygen and PPE kit shortages. So if anybody reported, a police case was lodged against them. Media was gagged for exposing all these fractures in the COVID response. In my state of Uttar Pradesh, where I live, police action was taken against those who had released dead bodies of their loved ones in the rivers because they had no money for cremation. There were thousands of bodies were found floating in the rivers. And instead of having some empathy and sympathy with those people, instead of providing them with proper cremation, the government was booking cases against them. You know, I can go on endlessly. I'm sorry, but I'll take just 2 minutes more. Jim?
Yes.
The government did not pay heed again to the second wave predictions because there was evidence that a second wave was imminent. Science and evidence-based transmission COVID efforts took a backseat. The pandemic was being dealt as a law and order problem, not as a public health emergency. Mm. And there was very little role of public health experts in decision-making, except those who were towing the government line. Science and evidence-based transmission control methods, they took a backseat. Attention was paid to physical distancing. I wouldn't use the word social distancing because in India already we have so many social classes. There's already too much of social distancing, which we don't want it to be there. And masking and preventing large gatherings. You must have heard of that Kumbh Mela, which the government had, where about 10 million took part, and they were all chock-a-block, and the photos and the images show no mask whatsoever being worn. And then there were the election rallies in Bengal, where the Prime Minister himself was welcoming the huge crowds without a mask himself, without wearing a mask himself, and no mask to be seen in the crowd. And the ferocity of the second wave proved the hollowness of government's claims that all was under control. On government papers, everything is under control. It only showed how fragmented and fractured the government response was. Almost in my city, in the second wave, and elsewhere also, almost every family has been affected, Jim. Either we have lost a near or dear one or have faced acute problems seeking timely medical care. No matter how much money they had, no matter how much power they wielded, they were all in the same boat.
Shobha, it's really, thank you for sharing all that, and deeply tragic and sorry that you're going through all this and all of your fellow country people. It is harrowing to hear, and I appreciate you being here and bringing that truth to us. I have a quick-ish follow-up question for you. So many things that you were saying just have harrowing reminders of HIV, politicization, law and order approach, criminalization, shaming, not following science. You know, this is part of the history of the HIV response. And so I'm wondering, HIV advocates and HIV reporters like yourself and others, what have some of you been doing to try to inform the response and improve the response? It sounds like you're calling out, you're calling truth to power. But can you tell us anything else that's happening in terms of the HIV response dealing with COVID?
Right now, Jim, because I know what you are telling about the history of the HIV response is true. But now I think the situation is very different, and we should have learned the lessons from what the HIV response looks like today. Mm-hmm. But we have failed to do that, unfortunately, because yet the HIV community networks in India, they played a central role in ensuring access to HIV treatment for the 1.4 million people in India who are on ART. And In fact, I was in touch with many of these community network groups. And in fact, more than 1 week before the first lockdown, the Delhi Network of Positive People, the DNP Plus, they had written to the National AIDS Control Organization, what we call NACO, to know their emergency contingency plans in case of a possible lockdown, because there was no scene of a lockdown at that time. The Prime Minister had said everything is under control. Then the National Coalition of People Living with HIV, the NCPI Plus, they also began planning 3 days before the actual lockdown was imposed, and they held online meetings with the NACO officials, raising concerns about service delivery of ART. And their biggest concern was that even if the ART centers were open, how would the people reach there when everything was under lockdown? So actually, it was these community networks which spurred NACO into action. And NACO then asked the state AIDS control societies for multi-month dispensing of ART and allowing any person living with HIV to get their medication from any ART center in the country. Because many people were far away from their residence and from their homes in case a lockdown happened. And even those taking treatment in the private sector were now allowed to take their medicines from the government ART centers, thanks to the efforts of AIDS Society of India. So just 3 days after the lockdown that happened. So
that's fantastic. Go ahead.
Yes. So even the HIV affected communities, they helped in delivering ART to people who were not able to collect it themselves. And members of networks like NCPI, DNP Plus, and the Gujarat State Network of People Living with HIV, they worked out local solutions. They used government ambulances, their own vehicles, mobilized help from others to get at least medicines or food delivered to those in need. And some members of these networks, they were on the roads for 8 to 10 hours every day for a long period of time, despite NACO taking steps. But there were many who could not reach the ART centers. So they were delivering the ART medicines to them at home. And they were also helping with food and also helping them to get special police passes. Because if these people were going to the ART centers, in the initial days, the police was harassing them. Yeah. In India, they have something called the Green Book. The people living with HIV. So the police would tear off their green books and say, you are telling lies and you just can't go anywhere. So it was the network members who really gathered support and tried to sort these things out. Until mid-April 2020, NCPI had helped over 45,000 people to have their ART delivered at home. And they were also conveying to the communities the importance of following prevention control. So the HIV community networks were very, very proactive to push government HIV agencies to coordinate with other departments and ministries to ensure at least uninterrupted drug supplies. There were hitches. I'm not saying it was problem-free, but they worked with actually they forced the government to work with them.
Right.
And that was important. And regarding the general other community, even I was a part of a group. We started supplying food to the migrant workers who were either stranded or were on the move. And we ran several local community kitchens for over a month in the first lockdown. And it was totally community-based and community-led effort, but it was a sporadic effort because we also faced the wrath of the government, because if somebody was going to deliver food, they were stopped on the way. Where are you going? Why are you doing so? And then during the second lockdown in April, 5 or 6 of us came together to start a People's Health Helpline, the COVID service. And now over 100 volunteers are involved in running this helpline to provide oxygen cylinders, oxygen concentrators, medicine, online medical consultations. In fact, we have many doctors from the US who are part of this group also, doctors of Indian origin who are giving medical consultations to the patients. So it has been inspiring to see local people pooling in money to get supplies. And those who had lost their loved ones, they donated their oxygen cylinder, that we don't need it anymore, so you can please use it for your health.
Wow.
So that has been inspiring. And now the pandemic has shifted to rural areas, and these services have now been relocated to about 17. We are catering to about 17 villages. Sorry for extending this, but I think it is important.
No, and I think it's important. It's very interesting, and it is inspiring to see the HIV community being so thoughtful, strategic, and creative in addressing the needs of our communities dealing with HIV. It sounds similar to what some of the work that Winnie has been doing in Uganda. Now, Winnie can't be with us on video due to connection, but Winnie, I believe you're here on audio. Can you talk a little bit about how COVID has adjusted your HIV response with the communities you're working with in Uganda?
Thank you so much. It was so great to hear from India and from Thailand on what is happening currently. It's not different from what is happening in Uganda. And as I speak right now, we are in a total lockdown. The president announced on 18th, and literally everything is in limbo. We're not able to carry out business as usual because public transport was banned, including private transport. So it's only essential workers like healthcare providers that are going on to do their work. So as civil society organizations and also as as a network of people living with HIV, we have a lot of work to do right now because of the challenges put forward by the restrictions. So because quite a number of people are not able to access their drugs because they have no transport means, others have been going to further districts because of the stigma, stigma is still prevalent in the communities, and someone would prefer to walk for a longer distance to get drugs from a facility or from a community where they are not known, So right now, as I speak, we are, as a network of people living with HIV, we are organizing a crisis meeting, because quite a number of people are facing hurdles. So we want to engage the Ministry of Health in Uganda such that we have issues of uninterrupted access of treatment within our constituency. But also as advocates, what we've been doing, we've been working with our PLHIV structures at national level and at district level, because some of the members work as expert clients in the facilities. So they are in touch with the community members and they are able to share drugs with them. But also we have been trying so hard to ensure that we avail people living with HIV with psychosocial support services. We have a toll-free helpline, which is called a Support on Life and AIDS helpline, with counselors who are online and they're operating virtually. So we've been able to share this toll-free line online. We have our network social support groups. We also have a PLHIV COVID response group, WhatsApp group with all our members, such that if someone has a challenge, they are referred to a nearby health facility to access treatment. And we are also working with our peers voluntarily. Moreover, they are committing their own resources, their own time to ensure that their colleagues access treatment. Actually, as I speak, I think I received like over 6 calls, peers asking me if they are able to be supported with some form of fuel to deliver drugs to people in the community that are not able to access medication. So that's what we are doing right now. But also in the previous wave, we had so many people falling out of care because they could not access food. So we've been lobbying different partners to help us with food so that we distribute it to the vulnerable communities, especially mothers and children who are not able to get food to take their medication. And maybe to share, right now, there's been a lot of fear, because of there have been so many tragic deaths happening because of COVID-19 in this wave, and yet the healthcare system is so strained. We have shortages of gas cylinders, and private healthcare hospitals are really charging people exorbitant fees, because of the treatment. So, and so many people are choosing to stay home. Others are not able to access any emergency treatment for COVID-19 because the fee is so huge. It can even buy you a plot of land, you know. So right now there's a lot of fear because everything is crumbling, you know. We had an opportunity last year to prepare enough, but because we thought we had few cases, we didn't foresee what was happening. And most of the partners and donors were giving us resources in preparation, but the country didn't have an emergency plan, response plan for COVID. So right now, there's a lot of fear in the community, and our role is to try to demystify the myths and the information overload within our members. That's what we are doing right now.
So just a quick follow-up question, Winnie. In terms of technology, how many folks do you think are connected and getting their information, through their phones or through online? And how much do you have to reach out to people directly because of lack of access to technology?
I might say it's quite a challenge. I don't think 3/4 of the population can access modern phones, you know, or can access internet. It's a few elites that can access a good phone, you know, with uninterrupted access to internet. So what we are doing as a network of people living with HIV is we have in every district at least have a PLHIV coordinator. And what we do is to call directly, you know, to call directly to relay the information that we have, to call directly to find out if they have any challenges regarding access to treatment, if they have any needs. So basically that's what we are doing. But personally, I'm a social media Greek. I love sharing. I do it wherever I am, in my house, in my bedroom, share any advocacy issue. I use Twitter, Facebook. So that's the only mechanism we can use to reach out to young people mostly who have access to internet, and probably reaching out to policymakers because most of them are on Twitter and are able to get this information. But for the majority, we have to rely on phone calls to find out what is happening.
Yeah. Wow. Well, thank you for your work. And it sounds like, once again, folks working in HIV have really stepped up in Uganda to help communities struggling with COVID. So thank you so much for sharing that and for the great work you've been doing, Winnie. Simon, you, before COVID, following HIV research on a regular basis and condensing it and helping it make it understandable for lay folks and people like me who are not as science savvy and yet need to understand these things. How has it been, or how did HIV prepare you for the literal avalanche, tidal wave, tsunami, whatever metaphor of sort of COVID research that has just been hitting us? And also, if you could speak to that, and also the importance of engaging communities in COVID research. I know one of the reasons why the CAB was formed was a lot of us felt like communities weren't really being included in trial design and protocol discussions. And I'd just love for you to speak to both of those issues.
Thanks. I think at the beginning, nobody really predicted how severe SARS was going to be, even when we had examples in other countries. And so it seemed like a relatively easy thing to add on a little bit of work to HIV reporting. I'll just cover some COVID studies, and that's really the best way of being able to know how serious it was going to affect HIV positive people. And it expanded over the year. So I write very little now exclusively about HIV. I just write about COVID-19 and the impact of co-infections. And I was surprised that lots of the skills that we had as advocates and community were really transferable from one virus to the other. And it probably put us in a really good position to understand, the dynamics of a virus, that the virus has a life cycle and that treatments will be effective if they target various parts of those life cycles. And having been involved in community advisory boards for HIV drugs, then it transferred over that there are certain things that community bring to research that you might miss if you're just a researcher. No matter how good a researcher, you maybe don't have the same connection with the people that will be enrolling in a study. So huge amounts of transferable skills, I think, from HIV. And also lots of the doctors, HIV doctors and researchers really quickly got involved in COVID research for new treatments, for vaccine technology, and for epidemiology, to understand those early days, understanding what on earth's going on, how do we reduce risk? And so we had lots of networks where we were already connected. And I think those HIV researchers were very good at involving community in the research. Like the first questions we had was about what are the implications for HIV positive people. And so even in an age where, at a high income country where we have digital medical records, nobody could even say how many HIV positive people were being diagnosed with COVID-19, not how many people were having the most severe outcomes in terms of being hospitalized. And so community groups and researchers together started linking the databases so we could have some idea of what was happening. And we also hoped very early on that if you were on treatment and had an undetectable viral load, you wouldn't be particularly badly affected by COVID-19 compared to the general population. And steadily, as the research grew, we understood that HIV was an independent risk factor for worse outcomes. And so it seemed important to be able to explain those things. And then there's a couple of times where we've been involved with the CAB that we're all members of, where we heard about huge amounts of studies for COVID drugs that really weren't going to go anywhere. Very early on, you had lots of studies saying that hydroxychloroquine wasn't going to be effective, and yet you'd look on a trial register and see 150 studies were then going on with COVID-19, and I don't think any of those research studies involved community. And so sometimes it was community saying these studies are no longer ethical, or this question's already been answered. And so some studies were very good at adjusting to standards of care when the research informed that, but others didn't. And I think that the crisis nature of COVID-19 meant that the community was left off the table when we could have had would have been much more effective to include us.
Right, just the kind of the rapid response. I know as a community member myself, I kind of felt like everything was just going forward really quickly, and for reasons that are understandable, but a lot of us were kind of left behind and grappling and wondering, are studies even bringing in people with HIV? There was early vaccine studies that were excluding people with HIV that we had to address, and we didn't know until kind of too late, and it just felt a little crazy, right?
So HIV community in the UK were very good at networking to cover all sorts of aspects of breakdown in services, and that included information about treatments and vaccines. And so there was a collaboration with there's about 60 or 70 online questions on different websites where we've tried to answer most of those questions. But we still don't have real data on what happens, on the effect of vaccines in people with low CD4 counts or with detectable viral load.
Right.
So we are hopeful and optimistic that generally, if you're on treatment, you'll get as good a response to vaccines. But now we're getting data coming through that the immune responses aren't as good if you have a very low CD4 count. And we're waiting on data. This data should be available quicker than it's becoming.
Yeah, and this is really important data for the HIV response around the world, for sure. So thank you for sharing all that, Simon. And Rob, working in the United States and working for an organization that really centers and focuses on Black people in terms of HIV, Talk a little bit about what Black AIDS Institute has done around the COVID response, and seeing as how COVID has also, not only does HIV hit Black people harder, COVID hits Black people harder than other people in this country. So can you talk a little bit about what you all have been doing at BAI?
Sure. So our formal relationship with the COVID-19 Prevention Network tasks us with kind of doing a lot of community education around not just COVID vaccine research, but clinical research in general, and then addressing medical mistrust, which we've been trying to do for years just around HIV. We just have a larger audience now. And even before my work with the Black AIDS Institute, just as a Baptist minister, February of 2020, at the end of February, we started doing weekly COVID updates to the congregation. And as an executive director of a CBO, community-based organization in California, we started delivering groceries very early on to our clients. And I think it really boils down, with our work with the HIV Vaccine Trials Network is really around educating Black and Brown communities about clinical research processes. I think since we have wider audiences for all of that, we can get the message out a little bit more, but it really boils down to kind of empowering other folks to tell the story. So like, I still have cousins that have questions that, I can answer, but and you can give the same information 10, 20 different times, but until it comes from the right person, it's not going to get through. There's an old African-American proverb, each one teach one. That's what it boils down to. The folks who are privileged enough to get the information have to share the information, and it's a chain reaction from that. So there's celebrity campaigns are helpful for some folks. The doctor might be helpful, the preacher might be helpful, but it really comes down to the individuals that you trust spreading the message. So we, it's like that game where you keep telling the secret and keep telling it. That's how we get the message out to folks. And so we're just kind of doing that work through our Black treatment advocacy networks around the country, just informing as many people as we can so that their reach into their social networks gets the information out there for folks.
So in terms of mistrust, I think oftentimes these terms can be conflated. So there's sort of vaccine skepticism and hesitancy and medical mistrust that there's overlap, but they're also very different, right? I mean, medical mistrust really speaks to, in the United States context, how we were founded and built on slavery and racism, and how that racism and white supremacy still really infect all of our institutions, all of our work. So there's that, and that includes how we deliver healthcare. So Black people are treated less than frequently in the healthcare system. So the medical mistrust is understandable. It's based on fact. It's based on experience. But then you also have to deal with vaccine hesitancy, and hesitancy can be good. Being skeptical can be good. Science is all about being skeptical and asking questions. So how do you, in your work with Black AIDS Institute, how do you kind of find the spot where you're addressing people's long experienced mistrust of the system in general, and then dealing with this new epidemic, this new virus, requiring responses that we haven't seen in this country for over 100 years, and now a vaccine that came to fruition very quickly. I mean, what are some strategies that you all have been using to kind of thread through that very complicated swamp?
Yeah, I think first, I think understanding that folks' mistrust or hesitancy comes from all kinds of different places. And so you really have to meet folks where they are. I think our approach to addressing medical mistrust is really giving folks all the information that they could ever want or need, like answering every single question so that they are informed enough to make the decisions for themselves. Like the guilt and shame piece didn't work for HIV. It's not a good strategy to prevent anything or to get folks to do what you want. So really answering the questions. Like I have friends who have autistic children who are, very vaccine hesitant because they've heard all these stories about vaccines' relationship to autism. you can dispel all that, but they're only going to listen to folks they really trust. I think another piece, though, is making sure that as we talk to folks, we're respecting their hesitancy. Like, it's okay. I think one of the first things I said to our congregation was, you can say no now. No doesn't have to mean forever. Like, you can say yes at a later point in time when you're comfortable. I think also it's not, some people are not going to ever get over their hesitancy or their medical mistrust, and they'll still get a vaccine for practical reasons, right? Because I want to go visit my grandmother in the nursing home, and I have to have a vaccine to do that. So I think answering folks' questions honestly, affirming that their mistrust or their hesitancy is appropriate and fair and not a bad thing, and then just meeting them where they are.
Thank you so much for that, Rob. All great advice and things we've certainly learned from HIV. So I'm going to ask the same question of all of you, and we're just looking at the time. We're about 20 minutes out. So I'm going to ask for people to be brief here, although this is a big question. With the COVID response, you know, we've seen extraordinary things happen in a year and a half. As devastating and tragic as things have been, we've seen vaccines come to fruition very quickly. We've seen the entire world, and yes, with big, you know, caveats, but the world come together and recognize this as a pandemic that needs to be addressed. We've seen resources brought to bear. Anyone with a TV or internet is now, you know, hears about epidemiology every day, hears about vaccines every day, hears about viruses every day. And before that, they maybe never thought about these things, right? So what I'm going to ask each of you is, what lessons have we taken, have we learned, are we learning even right now from COVID-19 that we could bring to bear to improve our response in the, you know, caring for people living with HIV, providing prevention options to people people who are vulnerable to HIV, and even, you know, thinking about our vaccine efforts and our other research efforts to improve treatment, diagnostics, prevention, and vaccines. So I'm going to go in a little bit different order, so to keep things mixed up. I'm going to actually start where we left off and see what Rob has to say about that, in terms of what are some of the lessons that we should be taking from COVID-19 and transferring into our HIV work, and how might we do that?
You know, aside from the physical distancing, one of my favorite things about the COVID pandemic has been telehealth, implementation of telehealth, both for primary care and HIV care, but also for mental health. Folks have more access to mental health care than they've had prior to this pandemic. And so I think not going backwards, but like keeping that stuff is going to be really important going forward, particularly with HIV access in rural communities. So I think, you know, the infrastructure piece around making sure that there is broadband access every place in the United States is going to be helpful in implementing telehealth and getting folks services where they haven't had them before.
Thanks, Rob. And same question for you, Shobha. And Shobha, you are on mute, my friend.
Sorry.
No worries.
As I said earlier, that there were so many lessons to be learned from the HIV clinical trials also, and the HIV community, which we failed to learn. At least in India, the clinical trial for the Covaxin, it raised lot many questions and many ethical concerns. And I think one thing which the HIV community can learn from the COVID, the R&D of COVID vaccine is how can we avoid any delay in translating scientific breakthroughs into public health gains. And because that was stupendous, the way the COVID vaccine came into being within a year. And like people, of course, there are reasons for that, but they put in money even before and they actually risked the money. Maybe the vaccine would not work at all, but still the countries had ordered for it and a lot of money was going into the research, and the regulatory processes, I think, were taking place almost simultaneously. So it reduced the time between the announcement of the result and reaching the vaccine to the people. And I think that is one thing which we need to learn. And I'm always reminded, of something different, but the female condom, which how many years has it been there? In India, many women still do not know. And I'm talking of the urban middle class, that such a thing exists. Forget about using it. So what is the use of research and all this when the fruits do not reach the public as soon as possible, and at least they reach the public? So I think that COVID-19 has fast-tracked all that, and it has taught us to sort of run the processes in parallel and at least cut down that time. I think that is one lesson which I think we have learned.
Thank you, and that is an excellent lesson. Winnie, I'm hoping you're still with us on audio. How do you answer the question, lessons learned from COVID that we can bring to bear in our HIV response, whether that be prevention or care or the research endeavor?
I think both diseases have lessons to pick from each other, because like HIV, we've witnessed a stigma among COVID-19 patients, and because of the silence, you find a scenario where someone in a family has COVID and they keep quiet, and then they continue going to work and infecting others, because we've attached so much to COVID-19, If you have COVID-19, it means you move a lot, you go to so many parties. So many people getting COVID-19 and keeping quiet, which also happened to HIV. Up to now, it's still happening, someone is living with HIV, but because of community perceptions, because the community is judgmental, they are not going to come out to access treatment, and because they're not accessing treatment, the community transmissions occur. So what I have learned is that if we do not address stigma for both diseases, COVID-19 and HIV, then we are not going to end the community transmission. So we have to continuously sensitize people about the prevention measures for COVID-19 and how to manage, it, whether at home or in the hospital, and also demystify the myths around COVID-19. So that's what I've learned basically.
Thank you, Winnie. And let's go to Midnight, same question.
Well, I think if anything, it really highlights the really core work that the community organizations are doing, and are able to do, and can do even more so. What Rob mentioned about, pivoting to other things that they could help the health services in terms of doing things online, multi-month dispensing for ARVs, dispensing PrEP, differently. I think there's a lot that can be done, and it can be done at scale, because in Asia we're struggling to do things at scale. So PrEP, for example, there's still regulatory rules around HIV self-testing. Can we get that out? How do we use the communities to do that, to ensure that the trust that's already been built can then, using new interventions and the way that it's being delivered through the trusted community organizations already. Last year in APCOM, so we do this condom distribution. This is during COVID-19, and we distributed like nearly 136,000 condoms and lubricants. So people are still wanting to access services. So we need to ensure those services are still being provided, and not just think about it's all about COVID only. We deal with sexual health, so people still want to have sex. People still want to have, enjoy sex. How do we then deliver that messages differently now with COVID-19? So I think we need to be more creative in terms of integrating the communities to be part of the national health systems and being supported doing that kind of work as well.
Thank you, Midnight. And Simon, same question for you.
Yeah, there's been advantages. There's hopefully some of the lessons about how you access healthcare and telemedicine will help. But more people have died this year. We're halfway through the year from COVID-19 than died in the whole of 2020. And there was the G7 summit or something came out with an announcement that 1 billion people are going to or 1 billion vaccines are going to be made available. And that's just terrible news. I mean, it's really terrible news, because I'm living in a high income country where we're approaching 80% of people have had at least one vaccine, or 60% are getting 2 vaccines, and then it will just fall off the table. It will be covered, thank you very much. And the world needs 5 billion doses of vaccine, and not by the end of this year, but 5 billion now throughout the year, and then everything else finishes next year. Because unless you have good vaccine cover, you're going to be stuck in 2020 for the rest of this year and next year and the following year. And that's just not acceptable. And so the lesson that COVID still needs to learn from HIV activism is that in 2020, in 2000 and 1999, when the HIV drugs came, we collectively, activists who were doctors and activists who were in pharmaceutical companies, found a way to make treatment accessible and treatment available to now 24 million people globally. And we've got to do something better with vaccine access, because otherwise it's not going to work. Nothing's going to work in any countries, because variants will develop, and we need to do better. And so vaccine research needs to learn more from HIV, I think.
Thank you, and excellent points. And we're now to our last question before we have some follow-up information from our hosts at IAS-USA. So this is a question, I'm going to frame it like this. You have just stepped into an elevator. Maybe you're probably wearing your mask, and you're in the elevator with one other person, and that other person is your president of your country or your prime minister, the top dog. And you're in the elevator, you have 30 seconds to tell that person what they need to do, what's most important for them to do right now as a leader of your country to address the COVID pandemic. What do you say to them in that short amount of time between when the door closes and you reach your floor where you're getting off? So I'm going to start with Shobha. And you're on mute, my friends.
Sorry, I was trying to drown away the other voice sounds. That please do not make this an event management affair for political gains, and do not discard science for your political aims, because in India, science and evidence-based measures took a backseat. So I'm talking from the perspective of my country. So please do not disregard science, because without that, because we have been promoting the cow urine and cow dung as treatment for COVID, and the health ministry has been endorsing it. So please do not use it as an event managed. It is not an event to be managed. It is a public health crisis, and do not deal it with as a law and order situation, but as a public health crisis.
Brilliant. Thank you, Shobha. Winnie, what would you say?
If I was then elevator with the president, I would tell him that we need an emergency response fund for COVID-19, because this healthcare system is drained. We don't have enough ICU beds, and we have stockouts of oxygen cylinders. This is our crisis. Please act up. That's what I would say.
Act up, fight back. Silence equals death. Absolutely. Let's go to Rob. You're in the elevator with Uncle Joe.
I'm in the elevator with Uncle Joe. I'm going to tell him, remember who invited you to the cookout, who got you to the dance, who put you in the White House, and make it happen, period. Healthcare, voting rights, make it happen.
And they're all connected, right? And for clarity, for those of you who may not be sure who invited Joe to the cookout, who got him to the cookout, very clearly Black people in this country got behind Joe Biden during the primaries and were the ones who brought him to victory. Clearly, without a doubt.
And then gave him the Senate. He owes Black people and people of color a lot, and that starts with our health care and our rights.
And we're currently in a battle right now to keep our voting rights that are just been chipped away in very dangerous times in terms of that here in the United States. Let's go to Midnight. You're in the elevator. What do you say?
So I'll be wearing this mask. And I'll be
Stunning,
saying,
by the way.
and I'll be saying, Thailand is starting to roll out the vaccines already this month. So we want to really scale up the vaccine rollout, ensuring that we have options people can buy and be able to bring in other brands into the country. And at the same time, to also then support the community-based organizations and fund them, from our own funding. Thailand has enough money to be able to do that, and actually ensuring that the most marginalized are not being left behind with the vaccine rollout and also their access to health services.
Thank you, Midnight. And last but definitely not least, Simon, you're in the same elevator.
Is there room for two people? I don't know. It's not a nice, you're not putting me in a nice position. I'd say follow the science and spend the money. You just got to recognize that equity has to be fair. Science has done an amazing job. There isn't going to be a treatment. There's no single pill is going to protect you from COVID-19. The vaccines are amazingly successful and better vaccines are coming, and you have to spend the money and vaccinate the world.
Brilliant. Thank you. And with that, I'm going to thank our amazing panelists for joining us here today. Winnie, Shobha, Rob, Midnight, and Simon, coming from all over the world, different time zones. Thank you so much for sharing your experiences and your wisdom, what we can learn from HIV and what we've learned from COVID. Also a huge thanks to IAS-USA for partnering with the COVID Advocates Advisory Board on this discussion today and really uplifting the work of society and community-based organizations and advocates on the ground who have played a really, as you've heard, critical role in the response, and a response that is ongoing. And clearly we are so not out of the woods. To Simon's points, we already have more people dying from COVID than we did all of last year. So we're continue to be in dire straits. And then something else that we have to have on our radar is long COVID. So people who become infected with COVID, a large percentage of people continue to have symptoms that last for a long time, 6 months to a year or more afterwards. And we're really not sure how to treat that, and we're not sure how long those things will last or how permanent they may be. So I'm gonna turn it over to our partners at IAS-USA for some final thoughts and some logistics before we say goodbye to all of you today.
Thank you everyone for attending this live webinar. The CME will be available in conjunction with an on-demand version of this activity, and additional information will be provided by email. Again, we'd like to thank our moderator and our panel members, and to the audience for your participation. And I'll hand it off to Mr. Pickett to close out this webinar.
All right, thank you so much, Jose. I definitely want to call out Jose and his other team members who worked behind the scenes and really helped us prepare for this logistically and to make this run as smoothly as possible. And I think from my perspective, it felt pretty smooth. I hope it was smooth for you all and that you all got something out of this. Please, if you're interested in the CAB, we are definitely looking for more people to join us. I mentioned we have about 125 members and over 250 of you registered for this webinar today. It would be wonderful to see 250 applications come in for people who are interested in bringing your energy and your creativity and your passion and your willingness to have hard conversations and to be in situations that are not always pleasant. To Simon's latest point, doing advocacy is oftentimes quite unpleasant, dealing with very unpleasant people or who can be very unpleasant. So we're looking for you. We're looking for you to join us and to engage us and to bring your wisdom and your experience to the collective fight. We have a lot of work to do. we have no idea what's in store for us in terms of variants, in terms of new waves of this virus, and certainly we can expect with global warming and the so many things changing on our planet that there will be other types of viruses that leap from animals into humans. And so how we handle this all now is really going to be a predicate for how we handle or don't handle what comes next. So with all that said, thank you all so much for joining us. I wish you all a wonderful day wherever you are in the world. Continue to have your coffee or other beverages, water, vodka, whatever that may be, and take good care. Bye for now.